Well, good afternoon, everybody, and welcome to this very unique experience for me of participating in the virtual Oley conference. I'm Dr. David Mercer, and my co-presenter is my longtime compatriot and friend, Dr. Kishore Iyer. We are both surgeons. We are both transplant surgeons, but we've made it our life's work, I would say, to focus on intestinal failure. And although we participate in the transplant side of things, I would venture to say for both of us, much more of our time actually spent on the rehabilitation end and on how those different worlds mesh together. And so they initially asked us to give talks. They said, well, could you give a talk on the medical management, and one of you give a talk on the surgical management? And we talked about that amongst ourselves. But for us personally, we often find the most fulfilling learning experiences we have are when we're just sitting around, sadly, usually having a drink and just talking about what we're doing. And I think that Kishore and I felt that perhaps the best experience we could convey to everyone was to just try to mimic that, try to make this very much like what we would be talking about if it was just the two of us and we were, the hotel bar at a conference after our talks or something. So sorry, I can just hear a little background stuff. I'm at the University of Nebraska Medical Center, and I run the intestinal rehabilitation end of things here. And Kishore is in New York at Sinai and runs the show there. And so I think we both large programs. We've known each other forever. One of the first people who ever trained me was Kishore. Hey,
David, I think it's actually the Falcon support. We have to request you to go on mute.
There we go.
Hopefully they got that.
Yeah, hopefully they did. Thank you, Kishore. So what we're going to do, everyone, is we're going to spend the first half an hour or 40 minutes talking about medical and surgical issues. And then we'd like to spend the last 15 or 20 minutes or so just kind of dreaming about the future and where we think things are going to go. And so in an informal way, I'm going to act a little bit like an interviewer, and Kishore is going to act like the interviewee, like the expert. And so what I really wanted to do is I wanted to start off and paint a picture for everyone of a patient that would be very similar to what I think either of us might see. So let's just imagine that our patient that we're going to talk about is a 56-year-old woman. She had presented to her local emergency department with abdominal pain for about 24 hours or so, got very sick in the emergency department, was rushed off to surgery. And at the time of surgery, they found that she had an extensive twist of her intestine on the inside, and they found a whole bunch of dead gut, sort of dead, where there wasn't much to do but resect a large amount. Now, as typically happened, she was very sick and had a sort of a very complicated hospital stay, multiple operations early on, and ultimately ended up being left with about 50 centimeters of small intestine, maybe about 2/3 of her large intestine, in the hospital for a couple of months recovering. And now that has been just discharged home and was discharged home, sort of being told, this is a catastrophic, life-changing event. Life will never be the same for you. You really won't be able to eat or drink normally. You're going to be on this stuff called TPN, and it's going to keep you alive, but it's very toxic to your liver, and it kills everyone in 2 years. And so you're really not going to have much quality of life, and you should probably get your affairs in order. But we would like to send you along to see the great and noble Dr. Iyer, who's at Sinai, who is one of the world's experts in dealing with this, because the only hope that you have is to have an intestinal transplantation. And so, Kishore, what I'd like you to tell everybody is this is a scenario that we see. So when a patient like this shows up for you guys in Sinai, what happens? How do they take us through the process? Who do they see? What do you guys do? And then we'll just jump back and forth and let this conversation evolve.
That's the perfect scenario, David, and thank you for that introduction. I think you set the stage very well. And of course, as you and I chatted, this is for us. This could be the only thing missing is a pint of beer in hand or a glass of wine.
Totally.
This is the kind of thing we might do, perhaps not so much on the common cases, but on what's coming down the pike or something exciting you did or I learned or whatever. But that's a good place to start. Hello, everybody, and I won't belabor the introductions anymore, but get right into this case. So this is just to recap, we now know this is a 52-year-old female who had, yes, a catastrophe. This is life-changing, that there is no doubt. She's been told it's doom and gloom. She's been told it's TPN and poison and maybe quite often, and David and I hear this a lot, has been told, oh, you need an intestine transplant yesterday. And, the answer is very far from the truth. So when we take a call like this, 2-3 times a week, and the disease might change a little bit, how quickly it happened or what it was. It might be Crohn's disease leading to the same picture over 20 years, or it might be a gunshot wound, or it might be a blood clot, as you described. But so the first thing we're doing is whoever takes the call in our office, I know the situation in Omaha is somewhat similar to ours. That's where I cut my teeth. So a lot of fondness for Omaha. And typically a nurse coordinator or a PA will take the call, speak with the patient, speak with the family. Sometimes the patient's too devastated even to talk, and it's a very concerned family member. And even from that first call, two things happen side by side. And one may not be obvious. There's a lot of reassurance and hand-holding. That's one. And the other is collecting and sharing information. So we have a policy. We do not see any patient in our office without collecting all the records beforehand. This was a somewhat straightforward scenario you described, David, but often these patients have been through many hospitals, many doctors. And so there's a lot of information to piece through, and we don't want to waste people's time. So we spent a lot of time looking through the records. And I will cut to the chase before passing it back to David and telling you, but for us, a patient like this, 50 centimeters of bowel, if you think in terms of inches and feet, that is just shy of 2 feet of bowel, a lot of colon. I will say right off the bat, I'm thinking, hey, this is not that bad. This is a pretty good scenario. We've got a lot of bowel here to work with. So forget transplant. Transplants at this point, not even on the table for a patient like this. We're looking to see what can we do, and we're collecting records. And typically we'll arrange for a visit. We insist that there's a family member present for that visit. There's a lot to take in. And typically for us, a patient like this would see a nutritionist, would see a nurse practitioner or a PA, would see a social worker, critical, and we can talk a little more about this. We'll see a medical person, we'll see a surgeon, and as it happens in our program, somewhat like you, David, I can double up as both a general surgeon with an interest in intestinal failure and a transplant surgeon. And that first visit is a lot of talking and exchanging outcomes and facts. I'm going to stop there, pass it back to you. Is that about what you might do in Omaha today?
Yeah, Kishore, and again, everyone, we do have a very similar philosophy about a lot of things. So it's very similar. We do spend a lot of time doing our homework in advance. And for people who are traveling, we're really trying to make sure that the experience is as smooth as possible. So if we have our own investigations to do, that's all kind of laid out in advance. But I think one of the things that you said that I find was most important in the initial visit is that conveyance of hope. Because most patients are coming to us, and often it's surprising how many people, you may have the same experience, they come thinking not only are they getting evaluated for a transplant, but that they're going to be transplanted when they come to see you, because they're just sometimes there are misperceptions about what's actually going to happen. So people show up thinking, gee, I've got an appointment with Dr. Mercer and I think I'm going to get a transplant next week. And we spend a ton of time telling them, first of all, it's not doom and gloom, that your life is very much the opposite, that there's tons and tons of hope coming in front of you. And as Kishore so correctly said, transplant is really off the table. It's not something that we have to contemplate right now. I think, Kishore, you're probably like me in that philosophically, I always approach everybody saying, what can we do to not transplant this patient? Accepting that there are some people who show up on your doorstep who literally are at that point. We are going to take some time about midway through our talk today, everyone, to touch on when we choose transplant and how we do that. But I think our approach probably as a multidisciplinary team is a lot like yours at this point.
David, it's funny. Everybody wants to see the chief, see the surgeon, see the transplant surgeon. That sounds magical. And I tell everybody, actually, in our team, what the dietitian does, 100% of patients benefit from what the dietitian does. 80% of patients might benefit from what the nurse or the PA does. The social worker, many of these patients need help. Then there's good medical management. You and I have been doing this long enough that we would get into the medical management, or they see a gastroenterologist working with us. And most of them benefit from medical management. We're both surgeons. We like to operate. We like big operations and difficult patients. And with all that, we're probably operating on about half the patients, maybe 2/3 at the most. And if we do all that correctly, at least in our hands, maybe about 15% of all patients we see might need transplant. That's in spite of us being a transplant center.
Yeah.
Is that similar for you?
I think so. And, and again, you're right, because everyone comes thinking, I'm going to go and see the surgeon, and we're we're like the least important people on the team in many respects.
Don't tell people that. They'll realize.
I know we need the job security. We have to keep the illusion up but I often feel like I tell everyone I'm a bit like the Queen of England. Everybody wants to see me and they're curious as to what I'm doing, but I'm often just waving my hand. So I do think that, you've built a good team and I've built a good team. And for folks, the honest truth is there aren't necessarily a lot of places in the adult world where that model has been developed. In pediatrics, we have that a little bit more widespread geographically, but there aren't a lot of places. So, for people who might be watching this at home, I find unconsciously, I make mistakes sometimes because I think about things in the way we do them. I'm used to our environment where we have all these wonderful experts and we have all this support, but I can certainly understand for a lot of people that, that may not be the case. Hey, Kishore, sometimes people don't have any idea who is looking after their TPN.
Yeah.
You find those sorts of things. People come often. I think patients sometimes can feel like they're on a deserted island and they're maybe trying to access social media. They're Googling Bowel Syndrome, you pop up or I pop up or someone pops up, and people are just trying to find, they're trying to find any port in a storm sort of thing.
It's a national problem. Unfortunately, there aren't too many experts in TPN management. It's a complicated therapy. It's life-saving therapy, but it does have some risks, and it need patients on TPN. Imagine getting your Big Mac and fries and salad IV. That's literally what we're doing here, and so it needs some monitoring. There's a fair amount of work, and this is an uncomfortable truth that it's not well reimbursed. So people who look after this are few and far between. And that's a problem that I don't think we'll solve today, but we struggle. We look after 60, 70 patients on TPN at any given time at home. Some of these patients are quite acutely sick nowadays, and we're still managing to keep them at home. That's a lot of work that literally you're doing on the side. But it's important that patients on TPN should be looked after by doctors. That might be a gastroenterologist, might be a surgeon, might be an endocrinologist even sometimes, but needs to be looked after by somebody who has some expertise, knows what to look out for, what to monitor. Coming back to your patient with the 1.5 feet of bowel and the colon, if you don't mind, I want to share a slide from Palle Jeppesen in Denmark. as you and I discussed, we pulled a few slides together, and the term that we often hear is intestinal rehabilitation, and it sometimes means different things to different people. And this is, I don't agree completely with this slide because he left out the surgeons, but I'm going to share it still, if you don't mind. Hold on a second. Let me go back and see if I can get the right slide up. Oh, that was not what I meant to do. I may need to go back to this for a second, David. Hold on, let's try that. Okay, do you see my slide? So on this slide, what Pale suggested, and for folks watching, Professor Jefferson's a very well-known gastroenterologist in the field from Denmark, and they obviously don't have such good surgeons as us, David, because there's no place for surgeons on this slide. But he suggests that intestinal rehabilitation is the idea of making the most of what the patient still has. So for your 52-year-old patient, we would start from below upwards, adjust the diet. Oral rehydration solution is a big part of it, and we can talk a little bit about that in a second. Anti-Diarrheal, notice the European spelling, anti-secretory agents. So these are ordinary medications that are available quite easily. In fact, some even over the counter, but some by prescription. And then at the very top of the heap is the whole new era of intestinal growth factors. So he talks of spontaneous adaptation. If you just support a patient like this patient might do well. Then with a little additional treatment, that's the conventional pharmacological hyperadaptation, used anti-diarrheals, other medications, you might do even better. And finally, for the patient that you're really stuck with, there are growth factors. I'm going to stop there and pass it back to you and see what your thoughts are.
Well, so looking over that slide puts me in mind of just putting into context for people. We're going to just start shortly, the two of us, getting into a little more of the nitty gritty of some of these things like diet and medications and stuff. But just putting this in the context of the field, when the scenario that I gave, we talked about somebody who had 50 centimeters or roughly, foot and a half, 2 feet of bowel, something like that. If you think back to classically, if we went back into the 80s and 90s, he would have said, anyone below 6 feet of intestine had a very poor prognosis, and that the only thing that you could do was transplantation or death from the consequences of parenteral nutrition. And we've gotten better and better and better. And this slide, in a way, it just shows that a little bit the way the field has evolved. And when we get to the end of our session today, where we're talking about dreaming in the future, bringing in growth factors and different things that we can do, I find it so fascinating that I intentionally chose this length of intestine because I sort of wanted to see what Kishore would say. And isn't it interesting that me reading in his face and his words he's not really all that worried that he can get this patient off of TPN. So now you guys, people who are watching, can see when he and I are seeing somebody who's got 50 centimeters, 2/3 of their colon, and is an engaged patient who's looking to help themselves, we're probably sitting as a team and saying most of those patients are going to do pretty well. Occasionally, it could take a while, and we can never promise anything. But we're at a point where, when we follow this sort of algorithmic approach, like we saw outlined on the slide, we can really do some very impressive things now, and it's striking. So now,
David, one interesting comment, sorry, to what you were just saying. Yeah. One of the things, I don't want to make it sound snide, but length does matter here. But obviously function is much more important. But I think what we get out of it, and I think I suspect as you drew up this case, that's what you were also thinking. What I find is, when you know quite precisely what the patient has, and unfortunately we don't always get that information. Surgeons tell us what they removed, they don't tell us what they left behind, and that's unfortunate. We should spread the word that it's more important to know what you have than what you took out. But but I always think of it in sort of three ways. At the extreme, somebody who has 2 inches of bowel, no colon, right off the bat, I know that patient's going to need TPN for the rest of his or her life. At
Yes.
the other end, somebody who doesn't have any residual disease, who has 3-4 feet of bowel, some colon, I'm going to say you're coming off TPN, whatever happens,
Yeah.
right? And then in the middle, there's the patient, somewhat like what you described, a little bit on the cusp. We're not quite sure if things go well, if this patient does well, if all the stars line up. This patient should come off TPN. And that's how, at least, I start to think of it. Does that ring with you?
Exactly the same. And, for everyone watching, again, when you build a team and when you been with your team for a while, it becomes a challenge. I'll say it becomes a game, but not in the belittling sense of the word. It becomes how good can we do? How great how short can we get this patient, and not just have them languishing and suffering? Because I will tell you, I mean, Kishore, I'm sure you've seen this too, is, they have to get off this TPN. And so they often tell them, you eat whatever you need to, drink lots and lots of high sugary drinks because they're filled with calories, drink a lot of sugary drinks, we're going to stop your TPN and see how you do. And then a patient comes to you and they're having 18 bowel movements a day, and they have, or if they have an ostomy, they have an ostomy output of 6 liters. They're drinking 1.5 gallons or 2 gallons a day to get through, and they're losing weight. Maybe they were 160 pounds going into this, and now they're 120 pounds or 110 pounds, and they're tired all the time and everything else. And so people have to understand that when Kishore and I and our teams are talking about managing a very short patient, we're not saying get you off TPN at all costs. We're saying get you off of TPN in a healthy way. And if you can't get you off of TPN, then maximize, make it as good as it can be, make you have the best function, the shortest number of hours, the best sleep at night, so you're not up peeing 5 times a night, and you're free during the day, and we've minimized your risks and all that. So while we're working on trying to rehabilitate people, we're still also trying to make day-to-day life just as good and as positive and as freeing as it can be.
And David, you made a very good point there about if we can't get somebody off TPN, then what are we doing? Our goal is still to make the quality of life good, to try and keep them complication free. But in this business, I tell people I don't like surprises, because the only surprises I get are unpleasant ones. And that's actually not true. We're pleasantly surprised. As you were saying, as you were describing the scenario of the patient who's not been given dietary advice, I was thinking of 2 patients I had. Both I was actually, one, I was not terribly surprised, but young man I inherited when he was in high school, and it was a tragic story. High school, straight A student, had developed what's called a midgut volvulus, his bowel twisted, and he lost his entire bowel in the high school field. And he was left with not quite 3 inches of bowel, which after a few operations, we were able to save most of his colon. We plugged the 3 inches of bowel into his colon, and we said, okay, let's do. Parents wanted transplant last week. And this was, believe it or not, this was about 7 years ago. The guy now, he gets TPN 2 nights a week. He works full time as an engineer, ironically in a pharmaceutical company, and he's living the life. And I think he would actually come off TPN, except on his side gig, he wants to be a bodybuilder. So we have to give him a lot of calories. So I can't get him off TPN. But the bigger surprise was the patient we got, somewhat similar age to your patient. 52, 54 years old, had a tumor. The tumor was removed. She was left with very little bowel. She's 25 centimeters of small bowel, not quite a foot of bowel, joined to half her colon. And I said, okay, you're going to get into trouble, but we'll do what you can do. We'll talk a little more about this shortly, but obviously not a candidate for any growth factor treatment. We did what we could with diet and whatnot. And surprise, surprise, a year and a half later, she's off TPN. And
Yeah.
she's living the life because she insists I see her once in 6 months. So it's worth the effort to follow dietary guidelines, to persist and see how far you can go. David, if you don't mind, just so we don't upset Joan, who really wanted us to share medical and dietary treatment, I have a slide that I pulled, not my own, but I thought was a good slide that I can share. Let's see.
Yeah, this is what I want us to talk about now, because I want to let's tell people a little bit about, a patient who does come in 18 bowel movements a day, diet, high sugary intake. I mean, it's very common, isn't it? Someone who drinks 6 Mountain Dews a day because someone's told them, oh, there's a lot of calories in soda. Make sure you drink a ton of soda, and we correct a ton of that. But take us through this and tell us the kinds of.
David, I was going to tell you, let me take a breath. You take us through this, but that's okay.
Either way,
I can walk through this. Just so I give credit where credit is due, this was work from Laura Matrice, who used to be in Pittsburgh, is now in down south, hopefully staying safe. Laura has done a lot of work in this area. And so you can see the do's and don'ts. And I actually like to tell people the don'ts is a very short list. The do's, you can do mostly anything. If you think about what should you eat if you have short bowel, I tell people, don't worry too much about the list. Then we'll get you to the specifics, and the specifics are a few. But think about how most of America should be doing healthy eating. If you think about that, you'd be okay for short bowel. And then what are the specifics? David already mentioned it. Don't drink a lot of sugary drinks, juices, sodas. Now, the juices are a trick one because people think, we've been told for so many years, isn't orange juice healthy? No, it's not healthy. Orange juice is just sugar and water, so don't drink it. And so sodas are terrible. Think about what people do world over to get their morning ablutions going. Caffeine is terrible. Get your bowels going. So soda is often a triple whammy. It's plain water, which acts almost like a Drano, flushes through your bowel. So sodas have the triple whammy of plain water, lots of sugar, and sometimes caffeine. And then, so avoiding simple sugars, don't live on a diet of cakes and cookies and candy. Does this mean you could never do it? We don't want a healthy patient who's slowly going insane. So we say, yeah, maybe you can do it once you get stable. Maybe once a week you tell yourself, today I'm going to have a treat. I'm going to have a small piece of cake, and I accept I may have a little more bowel movement. And so the do's and don'ts to me are really quite simple. I give the 30,000-foot view, and then our nutritionist breaks it down into daily menus. David, what do you think about this?
I think very much the same, which is that, again, people come afraid because they're afraid, oh my gosh, like I'm only going to be able to eat 3 foods now, and I love food, and I love all these different kinds of things. And I think we convey a very similar message that there's plenty on the do side, and there's just a few don'ts. And even the don'ts, as you correctly said, you can do them sometimes. They just can't be the mainstay of your therapy. So one of the things that I think is important for people to understand is when you have short bowel, you can only take in and absorb so much in a set amount of time. And so, I'll often turn to a family member and I'll say, now you have all of your intestine. So if you eat a giant meal at Thanksgiving, you absorb all those extra calories and you complain that you put on weight at the end of the weekend and everything else. But for the person with short bowel, if you eat a giant meal, you're still only going to absorb what you're capable of absorbing in a set amount of time. And so often, I think one of the really important things with eating, in addition to following the rules and avoiding, simple sugars, keeping up your salt intake, pushing towards lower volume, higher calorie meals, is matching your intake to what you're capable of absorbing. And so if you have a piece of intestine that's, 18 inches long, if you put a giant meal in, you're going to get what you can, but you're going to poop out the majority of that giant meal. And so you waste the pleasure, and you poop too much, and you waste your money. And so you would be better off having a smaller meal, taking in 300 calories or 400 calories. And let's say you're capable of absorbing 200 for sake of argument. If you take 1,000, you're going to poop out 800. But if you take in 400, you're going to get 50% of what you took in. And if you do that 5 times or 6 times a day, then suddenly you're really starting to deliver what your body can use. Now, nobody's got time in a busy life to sit down and have 6 formal eating events, right? None of us have the time to prepare a meal, sit down. So there's tons of ways that you can fit this into a normal structure where you've got kids that have to run to sports or you have a job you have to go to, but you can fit in how to get in a high fat, high protein, 300 calorie snack at different places during your day. And you can get in some different drinks and you can keep your hydration up. So for me, a lot of when I'm talking to people initially is sort of getting them used to the philosophy of saying you can still do more than you can't, but you're probably going to have to make some sacrifices and some changes in your life in order to have the quality of life that you want. Now, sometimes people, once they start to get buy-in, Kishore, hey, you probably see the same, which is it positively feedbacks.
Yeah.
People listen to what your dietitian says, they listen to you, and suddenly, just by changing their diet, they've gone from 18 bowel movements at your visit to 10 bowel movements the next week. And 10 bowel movements seems like a lot to people, but it's a heck of a lot better than 18. And when you did that purely by cutting back on Mountain Dew, people start to go, gee, that's a pretty fair trade. Now I can sleep again.
David, one thing I want to emphasize before we go to medical treatment, which is why I came back to this slide, people have been told often, and unfortunately even doctors and clinicians don't understand this always, been told you have short bowel, you're having diarrhea, drink more water. That's the worst thing you can do. The single biggest intervention I think we do in our practice is to tell people don't drink water. And that sounds, even for you and me, drinking water is not the best thing to do, but because we have enough intestine, it doesn't affect us so much. We'll come back to this perhaps in the question answer session, but oral rehydration solution that we call ORS is the sort of fluid of choice for these patients. It's not quite palatable for reasons that we don't need to go into now. It has the right mix of salt, and in spite of what we said earlier, it has a little touch of sugar to help push that salt and water into your body. So that's the first thing, the fluid of choice. Gatorade G2, we tell patients to add a little salt to it. That's a more palatable alternative. Our nutritionist has a whole bag of tricks to cheat with the ORS to make it a little more palatable. And I think that intervention has the greatest impact. I just want to move on, David, just so we stay to time. We won't spend too much time on this, but I will say that the type of patient you described, and really most patients in our practice will benefit. Oh, I'm so sorry. Will benefit from anti-diarrheals. These are just, things that slow down your bowel, things that add bulk to your stool. Imodium, even available over the counter. Lamodal needs a prescription. And there are other agents without getting into the specific group. But most, if not all, of our patients will need, and over time, they'll learn to adjust the medication depending on the response they're getting and based on the diet. And then we, of course, also do acid suppression, because as soon as somebody loses a lot of bowel, the stomach is just pouring out acid. And so we're keeping that suppressed typically for about 6 months to a year, though we often end up doing it long term. So, David, let me turn the questions over to you now for a second. There are many surgical options. I hear of this patient that you just described who came to our office, and I didn't immediately see any obvious reason to operate on her. But would you care to describe to us what are the types of patients that you're thinking, oh, this patient may need an operation, may benefit from something, and what are the operations? I know you send me a picture, and whenever you want it, I can share it. That's the one.
Well, okay, so let's talk a little philosophy again, because so much of the surgical end of things is philosophy. So I'm a big believer in, we want to maximize every bit of absorptive surface that a patient has. And so in many cases, that means restoring continuity. And so for everyone out there, what we mean by that is if the bowel is to the outside, maybe there's a fistula, so an artificial hole that's draining, and there's stool or digestive juice coming out of the front of the abdomen, we want to get those fixed. In many cases where there is an ostomy and we have the ability to take down the ostomy, to join the intestines back up and have that person pooping again and having all of the what we call the enteric stream, have everything going through the colon. Normally I always want to say, what can we do to make that happen? Now that has to be tempered by some reality. And so we, while we want to use as much bowel as we can, and I do believe when we have uncontrolled leakage, in almost every case, you're going to want to fix the fistula. I mean, in general, unless you're optimizing the patient first, assuming that you can do the surgery safely, you want to progress towards that reconstruction. I like the idea of reversing most ostomies where that reversal is technically possible and where it's not going to impact on someone's quality of life. And folks, where that becomes an issue is we don't want to put a patient into a scenario where we join you back up again, but we make you what I sometimes tell patients is a bathroom cripple, meaning we've joined your intestines back up, but you have to have bowel movements so frequently that you no longer have any reasonable quality of life. An 18 bowel movement a day means it's hard to get to the store to get groceries. It's tough to run a kid to a soccer game. That's probably waking up 3 times or 4 times that night to have a bowel movement. It can be wearing diapers and accidents in the night in the bed and everything else. So there are some instances where we say getting things joined back up again and having you poop again is not necessarily advisable, at least at this point in time. Sometimes we have to go down the rehabilitation process for a while, get things better before we do that. So that's my initial philosophical thought is I want to restore continuity and maximize absorption. Now, where do I think the role is for surgery after that? For me, then, once I've got everything set right, that's when I want the team to go crazy on the patient, and I want to maximize diet, maximize fluids in, optimize medicine, if they're using some tube feeds or supplements, optimize that. When we've done everything that we think we can do, and we've weaned TPN, we're down into the best possible spot that we can, but let's say we're still stalled. Now you're looking to see, is there something that I can do to make this better? And thank you, it's very apropos that you would pop this up. In some cases, folks, when you're talking about doing something as a surgeon, perhaps there's a narrowed area, there's a blockage. And so what we're really doing is we may just need to go in and do some good old-fashioned general surgery. We might have to go in and just take out a blocked piece. For patients that have inflammatory bowel disease, sometimes, the gastroenterologists, with the best of intentions, are doing everything they can to maximize your medical therapy. They really have been taught quite correctly, don't give up on bowel needlessly. But sometimes the Achilles heel of a patient is a 5-centimeter piece of burned out Crohn's disease that's strictured down, and they're suffering and can't eat, and they're dilated and swollen, and all they really need is a 90-minute resection, end-to-end anastomosis. The angels come out, the sky's clear, everything is better, and things go great. Folks, the slide that we're seeing now, these are a little.
I don't know if you can see my pointer if I do that.
Yes, I can.
And so I'll follow your cue.
Thank you. So one of the things that can happen sometimes to patients with short bowel syndrome is that, for reasons we don't entirely understand, and it's perhaps a little more common in children than adults, but it still does occur, is the intestine will begin to dilate and stretch. And the intestine needs to be able to squeeze effectively to push food along and to help us absorb. If we take that tube and we stretch it, it wants to squeeze, but all it can do is that on the edges. So it's not propulsive. It's not sending fluid forward. Sometimes that's manifested for a patient as a bloating feeling like you're obstructed, and then you suddenly have a bunch of vomit, or you suddenly have a rush of bowel movements or something like that. Well, when that occurs, when we have that dilation, we can take advantage of it surgically, sometimes to do things to improve those symptoms, eliminate the dilation, but at the same time give you perhaps better absorptive surface. So here you can see up in the upper corner, the LILT, the lilt. This is very, very commonly referred to as a Bianchi procedure. This is an operation that I first saw because Dr. Iyer was performing it when I was a trainee, and he's worked with Bianchi. I mean, he's there and I'm going to have him wrap up this by putting the whole field in context. But this is a way, everyone, where you take a big dilated tube and because of the way the blood supply of the intestine works, you can split that one tube into 2 tubes side by side, and then you can join them together. And so in effect, you can take that dilated piece and without losing any of it, you can turn it into something that's twice as long. Now, below that, down below, you see something that's called a STEP, a serial transverse centroplasty. That's a more novel, I guess it's not that novel anymore because it's really been around for 15 years. But what that is we can take a surgical stapling device that fires parallel rows of staples and cuts between them. And by placing the stapler back and forth in a zigzag fashion, we can take that dilated tube represented in the center of the image, and we could turn it into this much more narrow zigzag tube. And so what then happens is that effluent is going like this through the intestine, but we maximize the surface area exposed to that fluid. And that alone, that can really give people a benefit, alleviate a lot of symptoms and not lose absorptive surface. In the upper corner above that, opposite that, is a slightly different approach. This might be something you might do where you would say a patient has plenty of length, but it's too dilated to function. And so we can take a big tube and we can cut some of it off, reducing it down to a more normal tube. What's nice about this is it leaves the bowel in a very natural conformation. It's easy for us to reoperate on it. It leaves it sort of squeezing the way it's supposed to squeeze. But the downside is we discard a part of the absorptive surface. So it's not necessarily an approach that I take to a patient that's very short, but if I think there's plenty of bowel, I'll do that sometimes because I just think it's a pretty operation. And I think that, you know, when I get to patients that are in that 80, 90, 100 centimeters where I'm not so worried about length anymore, sometimes I think that's a good option. The last one down in the corner is not something I've ever done, and I don't know if you ever have, Kishore. It's been described of late, and it's basically a way to, I'll often describe it if anyone here has ever had Pillsbury dough. And you take the wrap off a batch of Pillsbury dough, and then it goes and it kind of twists. And that's the dilated bowel. And if you twist the Pillsbury dough container out, it gets a little longer. And that's kind of what that last procedure is. Now, Dr. Iyer,
I'll never look at you again without thinking of bacon.
Kishore has been with science in the field right from the beginning.
I think that's a very good summary, David. I think you captured that correctly. The only thing I will say is really nothing to add about the specific operations. You mentioned philosophy, and I think an interesting way of looking at this is what our colleague Dr. Hyung-Bae Kim and Boston Children's talks about. He says we've been focused so much on lengthening the bowel for so long, when in short bowel, the problem is often that it's too wide and you want to narrow it. So it's the diameter maybe that we need to pay more attention to rather than the length. But, you know, that's important. Okay, come back to your patient, the 52-year-old. I think she's doing better and better. What's going on? Suddenly you have a line infection. Should she go to transplant now?
So this is good. So that's a good segue. I like it. Well done. Everyone, we did not rehearse this. We didn't plan it. So I like that. So let's talk transplant. Let's talk indications for transplant. Well, so Dr. Iyer gave me the idea, okay, now there's been a line infection. Okay, well, I think the short answer to this scenario is we wouldn't recommend transplant in this case. But why do we transplant people? Well, we consider transplant for patients when we feel like the risk of carrying on in the path that they're following is greater than the risk if they go into transplant. Transplantation, not just in intestine, but in any category, is about balancing risk. You have a certain risk of going on with life, not being transplanted, and a risk if you have a transplant. We know the risks in transplant because we've got all the data to show us here's what's happened in the last 25 years. So what we want is we're looking to see have people develop indications. One of the reasons we might consider transplant on a patient is if they're getting frequent life-threatening line infections. So not just an infection with a fever where you go on antibiotics and everything is okay, but where you come in on death's door and you're in the intensive care unit and very, very sick, or you're starting to get really bad bacteria where we're running out of antibiotics, funguses that are very difficult to treat. Those are times when then we're sitting with our team and going, gee, one more of those infections could be your last. Now maybe it's time that we should think about transplant so that we can do what we can to get rid of that central line and obviate that risk. Other reasons would be if because of having central venous access for your TPN, now you're getting clots and you've lost, we think about 2 jugular veins, 2 subclavian veins, 2 femoral veins. We have lots of other ways we can find access, but those are the biggies. If you start to clot those off where you can't get your intravenous in for your TPN, well, then we have to think, is it time to go to transplant? A very common cause when you and I were training, not so common now, but it still happens, is liver disease. You know, we used to be that was one of our main reasons, was people getting sick from TPN and their livers were failing, and we had to transplant them. And you know, little children would come in on death's door, and we would rush to transplant them as quickly as we could, and some would make it and some wouldn't. And then finally, I guess we get into the a little more nebulous, which is the things like lack of reconstructability or, you know, significant impact on quality of life, where you can argue both ways and neither one nor the other is necessarily correct. But so what do you think, Kishore? I mean, how have the indications changed? How do you think?
David, I mean, to me, definitely the indications are changing, even if they haven't yet officially changed. And I'll tell you why I say that in a second, but I just want to provide the context. For the patient we were talking about, one-line infection, absolutely not. We just need to treat that, keep her safe, and think about why it happened, what type of bacteria it was. I don't want to spend too much time on it, just I'm keeping a watch, keeping a watch on the time. But the complications of line infections, we can talk about using ethanol locks, antibiotic locks to reduce the risk of infection. As you said, liver disease has now become infrequent. So it's rare. There are patients who do get recurrent infections or recurrent fungus infections. I've got two patients right now, one with bad infection in the heart valve, and this is now her second infection. She's infected her spine about 8 weeks ago, and now she's got a heart valve infection. So that patient needs transplant, assuming we don't get her off TPN, but not for the patient we just discussed. But I do think there's something very important that I've been looking at lately. And I think this is, it brings me back to what I tell patients and I tell the team. You know what? Yes, I run the program, but I see my role more like the foreman of a Jiffy Lube. You know, you take your car into Jiffy Lube and somebody has to decide, does your car need spark plugs cleaned? Does it need some oil, or does it need the whole engine changed? That's actually my role. And sometimes that role is tricky. I know how to change the engine, but should I change the engine is sometimes a difficult question. And I want to share with you two pieces of data that I think are at least worth thinking about, even if I don't answer your question directly. Here's the first one. This is already old. And I'll tell you, this morning when I was putting the slides together, I couldn't actually I have a slide with the more recent data that looks even more compelling, but this is enough for our discussion. And on the left side of this panel, as I'm looking at it, this is data from a very big French group that looked at adult patients on TPN. And what they showed was, by the 5-year mark, if the group of patients who were on permanent TPN, meaning they really could not get them off TPN, this is permanent TPN dependence, they had 5-year survival in that group of 60%. Okay, this is a expert group on TPN, one of the best in the world, managing most of the TPN in France. Now, this is data from the US. This is not a single center. You and I both know single center data from the experienced centers looks better, but this is national data on outcomes for transplant. And you can see 5-year mark, the survival is at least 60%, actually looks better. So the trick for us, I think, and we won't answer that question today. That's material for a debate another day. But the trick for us is to try and find the patients on TPN who are not doing well, who are getting 5-year survival of 60%, and then look to see, can you do a low-risk transplant on them and that group get a better survival? Also, keep in mind, big difference between these two groups. This group, by and large, is eating and drinking. This group, by definition, is on TPN. Just something to think about. And I just want to share the same data in children. Oh, I'm sorry, that's the wrong slide. So let me find the pediatric slide here. And the pediatric data actually just came out recently. And let me see if I can share that with you. Now, this is the group from Boston that presented their experience, and this is a recent paper, came in 2016, and what it showed was the kids who did not achieve enteral autonomy. You and I both think that kids on TPN really do very well, and it's rare that they need transplant. 5 year survival for kids who are unable to come off TPN is 78%. And when you look at what is the survival for kids under the age of 18, this is national data 2020, so more or less comparable data, 78%. So I'm not saying, I'm not putting this up to say we should be transplanting everybody willy-nilly, but just to say that I think we need to move away from saying we should only transplant patients who are at death's door, because we know those patients don't do well, but try and look at this problem a little more intelligently to see who's showing signs of not doing well on TPN, and perhaps that type of patient should move towards transplant. But that will not be the case for our patient. Let me ask you this. There's a lot of excitement about growth factors.
Yes.
At what point would you consider this patient for teduglutide, which is now the commercially approved growth factor called Gattex?
Yeah. So that was really good discussion. What he just talked about is something that we, as transplant surgeons, we debate, argue vehemently and stand up and yell at each other in conferences, and because that's really the crux of the field right now, is who are those people? How do you pick them out? And it is tough. It's funny because as a transplant surgeon, I've become, I don't want to say I'm anti-transplant, but I've definitely become very pro-rehabilitation. And partly I feel that way because of what you just brought up, which is the question of growth factors. As I see increasingly patients shorter and shorter and shorter coming off of TPN, I feel like I want to wait, because I feel like the field is evolving. And if I can keep these patients alive, maybe they can come off. So Dr. Iyer was talking about, Kishore was talking about, this growth factors, and Gattex is the one that we have available right now. And we have a number of different things coming up. So would I put this patient on a growth factor right now? Well, not right now, not when they walk through the door, because for me, the best thing to do is to be able to come off of your TPN with no medications. That would be the best, right? If you could just modify diet, and this patient did well, 4 or 5 times a day, everything was doing okay, and they came off of TPN, everyone's a winner. No meds, life is good. And we slowly add medications in to get closer and closer and closer. For me, in a patient like this, what I'm looking for is, I want to see how low can we get their TPN and have them maintaining a safe weight that they're comfortable with a decent quality of life, doing everything without using a growth factor. And that's where I then feel like it's time to bring in the Gattex. So if we were to take the scenario I gave, fast forward 18 months, and let's say now we've got this patient on 5 days a week TPN. And
you can do better, David. I'll give you 3 nights a week.
Okay, 3 nights a week. Perfect. We're down to 3 nights a week TPN, and we've got the volume down to 2 liters a night. And remember, originally, folks, maybe we were on 4 liters 7 days a week. And we're maintaining a weight at 130 pounds, and at 5'6", we think that's a comfortable weight, and quality of life is good. This is the patient who I think is suited for the home run of a growth factor, where you think when you put them on, they're quite likely to have an excellent adaptive response and then come off of TPN. Now, it's not to say you can only, this is the only people that it can help, because they can help lots of other patients. But this is the approach that I've taken so far, Kishore, which is to get them as far as I can and then bring it in towards the end, with the idea being these meds, everyone, once you're on them, I really do think they work beautifully. And I think most patients tolerate them very well. Some don't, but most do well. But you do have to stay on them in general. When you come off, you tend to revert back to the way you were. Some people keep some positive benefits, but you do tend to revert back. So
David, do you mind if I interrupt you?
Yes, please.
Just to tell the audience that you and I really did not rehearse, but I feel like you're saying you're stealing all my lines.
Okay, well then I'll shut up. You go for a while. You go for a bit.
No. You said it perfectly. What I wanted to share was, this is from our our mutual friend Francisca Jolie from Paris, who's of course done a lot of work in this area, and she shared the slide with me, and this is the recommendation that ultimately was adopted by the European Medicines Agency, and it actually exactly adopts the approach you just described. So teduglutide, look, we prefer the pharmacological name, but it doesn't roll off the tongue. I'm just going to call it Gattex. In Europe, it's called Revestive. But so Gattex is indicated for adult patients with short bowel syndrome who have intestinal failure. And then she said patients should be stable following a period of intestinal adaptation after surgery. So let them recover from surgery, go 6 months, you put the bowel together. If there was a stoma, you took it down. And what next? Don't start treatment until the patient has had some time for stability, like David described. You've adjusted the diet, you've adjusted the medication, you've optimized IV fluid, nutrition support, and once that is done, think about who are the patients who should not get Gattex. And most important among them, and I want to just take an extra 30 seconds on this, if you've had a cancer, if you've had a lot of colonic polyps, you should not be getting this medication. But other than that, it's relatively speaking quite a safe medication for how efficacious it is. So provided you've ruled out all those conditions, then this is a patient who might be eligible for Gattex. So very similar approach to what you described. Spend some time, focus on the diet, focus on the fluids, focus on the anti-diarrheals, and who knows, you might get this patient off without any further fancy treatment. But if you're really stuck, then this may be a candidate for Gattex. If you don't mind, I want to go to the next slide.
Yeah.
I just put up for the audience, what is the current experience we have with patients coming off TPN with Gattex? So we reported we looked at all patients who had received Gattex from all of the trials. That paper came in 2017. And you can see here, just about 16% of patients came off TPN completely with Gattex. But keep in mind, that's only patients who came off completely. There were other patients who got 2 nights off, 3 nights off, etc. And then we looked at our own patients at Mount Sinai a couple of years ago, obviously smaller number of patients, 18 patients, and close to 2/3 came off TPN. Many of them had colon, and you'd expect that group would do better. And this paper has just recently come from France, from Francisca Jolie. About 1/4 of all patients came off TPN completely. And I think that's good to know. So once you've exhausted all your standard diet and medical treatments, etc., I think there is a role for Gattex today. David, you are a part of this trial. You want to speak about the pediatric trial?
Well, sure. So in pediatrics, when we did the trial, we fundamentally also demonstrated, the drug is well tolerated. It's pretty safe. It achieves its endpoints. It leads to a reduction, a greater than 20% reduction. And in general, it was kind of around 40% or so. Now, so this became available, everyone. The pediatric approval was, gosh, now it's probably 16 months or something like that. Yeah. Maybe a little more, 18 months. I don't remember exactly, but so it has had a dramatic impact on our practice here. I mean, we now have 25 children on teduglutide. And we frankly, and it works very well. I think we're going to be able to demonstrate ultimately that we're getting, it's really helping us to take central lines out. We're getting people off of TPN. We're getting children enterally autonomous. Once you just couldn't quite ever make it, and we couldn't quite keep growth going. And so I think it's really finding a role. I find pediatrics is fascinating because in pediatrics, everyone, this is your most adaptable time of life. And you could make an argument that when you're a kid with short bowel syndrome, you have to not only support existing, but you have to support growing. So in many respects, pediatric short bowel syndrome is something that you could grow out of. When you get to your final adult size, you finish puberty and you're as tall as you're supposed to be, your calories then go from, we're having to give 70 or 80 kilocalories per kilogram per day to a 2-year-old. but a fully grown adult might only need 22 or 24. So in a way, I'm viewing pediatrics now as what we might need to do is just keep kids healthy and alive until they outgrow their short bowel syndrome, which we would have a reasonable expectation as they get older. So I found it's had a very big impact on our practice. We've used it extensively and we've had really positive experience so far.
David, you made a comment about this earlier about leaving patients on it. I'll tell you that I've had 2-3 adult patients who came off TPN using Gattex, and lately, with some help from me, we've actually taken them off the Gattex and maintained them without TPN. What's your view in kids? You know, there's some concern about using a growth factor long term in a child.
Yeah. So our approach is going to be, and we're in the midst of this, everyone, because we're only sort of, I mean, again, it's in the first year of the experience, but I think our approach is going to be, once we get patients off of TPN or whatever the new baseline is, let's say they don't come off, but they're now at a new baseline and we can no longer wean them anymore, then I want to start weaning the medication back, probably very much like what you would do, which the idea would be, drop a dose a week, leave them for a few months, see what happens. If they're stable, drop another dose. And just because just as a general principle, I always feel like we should use the least amount of any drug that we're using. And I think your point, Kishore, about, if you're introducing a growth factor into a child that maybe they now need for 70 years, what's going to happen a few decades from now? So I do think that's something as a community we have to be cognizant of, try to minimize its use when we can. We've not seen any ill effects so far, but we're just in the infancy of this era. So I'm hopeful, and I tell parents that I'm hopeful your child, as they grow and their bowel grows in proportion to their body, the things we need today when they're 2 might not be what we need when they're 8 years old or 10 years old or, Lord willing, 18 years old. So I'm hopeful that we can wean patients off of drugs as we get further along.
David, I'm just looking at the clock, and we're in the last 5 minutes, I think, and I'm hoping if we overrun, Joan will allow a minute or so, or I know Joan long enough that she'll just cut in and tell us enough already. So with your permission, I'm going to run through the last few minutes of what we see coming down the pike.
Yeah.
I think you and I will both agree that these are exciting times in intestinal failure. Suddenly, there's a lot happening, and I will say also that this is a good time to acknowledge that the pharmaceutical companies that have been involved, and just full disclosure, I'm a scientific advisor to many of them, as you are, Dave. Yeah, but I think the pharmaceutical companies have done a fantastic job about understanding the field and recognizing that patient education and supporting understanding of the disease is important. So my before I want to hand this to you for a second, David. You were very involved with the trial design of this, but just to say that there are, of course, there's Gattex, and we're learning more about it. It's clearly efficacious. By and large, for being a growth factor, it's a very safe drug and allows many patients to come off TPN or significantly reduce TPN. What's exciting is there are now newer agents that are coming down the pike that are going through trials. I think, David, you can speak about glepaglutide, perhaps.
Yeah, the newer agents, everyone, they are modifications of molecules so that they can last longer and longer. And the idea is, right now, we do Gattex as a daily injection, but could we get to something that is a weekly injection? And so we're in the process of testing. Right now, we're in clinical trials with this drug, which is glepaglutide, and we will be starting clinical trials in the next one, apraglutide. That's probably going to start sometime in the next. Yeah, there you go. That's.
So, I think apraglutide. So what you can see here, and I don't want to spend too much time on this, but you can see this is what's called the half-life, and these are steadily longer acting agents. I can't even see the small print, but glepaglutide, then apraglutide. But there are new agents, and of course, ultimately, how any of these drugs works, how well it works, how safe it is, how efficacious it is, will depend on the results of the phase 3 trials. But even David and I know of at least 2 agents that are coming down the pike. Glepaglutide is already in phase 3 trial. Apraglutide, I think, is coming on relatively soon. So I think what is going to happen, I suspect, and I put this down in my summary here, I think long-acting growth factors will be the future. Can you just imagine you go to your doctor once a week, you get a shot, like a vitamin shot, and that helps you either reduce your TPN or stay off TPN completely. Exciting times. And then
Very much so.
something else that is very interesting. What we've talked about, Gattex, glepaglutide, apraglutide, is all GLP-2. And if we have time, we can talk about it in the question and answer session. But this is something called GLP-1. It's a different growth factor. It's actually approved for treating diabetes. And this was a very short study, what we call an open label study, but it was well done. And they showed that GLP-1 actually helped patients with short bowel. So you can speculate, read the tea leaves and say, oh, maybe 8 years from now, you'll have a combination shot that you take GLP-1 and GLP-2 and you say, wow, now I'm off TPN. So there you have it. I think I'll let David take this to the top of the hour. It's been fun chatting with you, David. It would have been
as always,
beer, but we'll make the best of what we have.
Yes. Yeah. So thanks, everyone. We just tried to touch on a whole bunch of things, and I hope you can appreciate just from the discussion. We're geeky enough that we can split off and talk for, an hour on any one of the little topics, like any of it, rehydration solutions or drugs or surgeries or whatever. So we didn't want to get too much into the weeds on any one thing, but I think we'll wrap up our discussion, and we would be more than happy to take any questions when that time period comes. And we have another session in a few hours, don't we, Kishore? A breakout.
Yeah, but though I did get a text from Joan, which actually is because you guys did a good job with the time. I think I'm reading this correctly. Because you guys did a good job with the time, next round of martinis is on me. No, I'm kidding. Joan didn't say saying it. But I think we're close to the top of the hour. This has been fun. As you said, we can keep chatting. We do have, I think there's a question and answer session, which will be live, and hopefully people will have questions for us. And I think we have what's called a breakout session. We're just going to be doing more chatting late in the afternoon. David, thanks as always, and we'll stand by for more guidance from the organizers.
Good to see you, friend. Bye-bye.
You too. Take care.